And then by way of a very quick update, you may be aware of an event that we hosted last year in the House of Lords to raise awareness of young onset dementia, and particularly the support groups that we facilitate. I just wanted to update you in respect of one or two developments that have arisen as a result of that event. And so very briefly, they were to mention an ongoing engagement with the Royal College of Optometrists, which is proving incredibly helpful, obviously, to the PCA research unit at the Dementia Research Centre. But relationships that weren't currently in place involve and include a relationship with the College of Social Work, who are coming along to one of our annual seminar events. One of their training and education officers is coming along to one of our annual seminars to increase the knowledge and awareness of young onset dementia that social workers consider putting into the training packages they provide. And the other two interesting relationships that have come out of that event are a relationship with Relate counsellors, and again we've been invited to partake in a campaign this spring to bring young onset dementia on board within their remit. And significantly for today, a relationship with the College of Speech and Language Therapists. Now, specifically with regards to today, we have been asked whether there are people who would be willing to be videoed as part of a video package that the College of Speech and Language Therapists are preparing as a training resource. They've approached us as facilitators of support groups such as these, and so I'm approaching you on their behalf. If you think that's something you would be interested in, it's not a support group initiative, but I can be the link between the College of Speech and Language Therapists and people who have a language difficulty as a result of their diagnosis. I think it's a really exciting opportunity for us to get on board, and I'd love to hear from you during the break time if you'd like me to take that further on your behalf. I'm not going to say any more. I think it's important that we get on with the agenda as is set, and so it is my pleasure to introduce Eneida Mioshi, who is a lady with an awful lot of expertise, and she has an amazing ability to bridge the sort of gap between research and practical application. And so I really hope that the session that she's prepared for us today is of help and benefit to everybody here. Without further ado, I'll hand over to Eneida. Thank you.
Okay, first of all, I'd like to say thank you so much for the opportunity to come here. I came from Cambridge. It's a great pleasure to share some of the research that I've been doing, especially with the families, because you're the main reason of my research. So I feel more nervous talking to families than to scientists, because I think you are the ones who can best judge what I'm doing and help guide the direction of the research we should be doing. So also I have a funny accent. I come from Brazil, so if anything is not so clear, let me know and I'll repeat, okay? So this research really started, I started my professional life, as just said, as a clinical occupational therapist, and the patients were referred to me as Alzheimer's disease, and they just didn't fit when I was working with them and with the families. You know, you read the books, you understand what they should be exhibiting, abilities they should have or have lost, and the patients were not just fitting. They were all very atypical. Well, it became clear later they didn't have Alzheimer's disease, and I only learned that when I started working in Cambridge with Professor John Hodges, who is an international expert in frontotemporal dementia. So in the last 12 years, I've been working mostly with uncommon dementias. They are the onset dementias, the dementias which don't fit with the general Alzheimer's dementia picture. So being an occupational therapist, you start working with the everyday issues, and most of the researchers, you know, from the biomedical side, they're focusing on different aspects which are important for understanding the disease, but are a bit more distant from what you see in everyday living and after the diagnosis is made. So there's a lot of research in pathology, understanding the changes in the brain, the genetics of it, which is very relevant for family members, neuroimaging, when people get scanned, with a lot of testing for psychology, neuropsychology, all the memory tests, the language testing, But for me, really, what's important, it's the middle of that. When you get everything together and you understand finally the diagnosis, and then what do you do with that? And once you go home, how do you manage that? So it's a relief to have a diagnosis, but the challenge really remains in the next few years when how am I going to approach this, the person and the family. So that's where my research sits. Well, care burden. That started because by doing the functions that they do all the everyday life issues, you have to go via the family to identify the issues which are happening. And by spending hours with each person, interviewing them, you start realizing that there are factors there happening which are affecting the ability of a person to continue to live independently. But there are so many other issues that the family members are facing, and these are also being affected by the dementia. So, care burden was an area that I started researching as a sort of an accident, because I started focusing very much on how the person can live at home, independently or not. And then you start seeing that the issues that are surrounding that person are very complex and as important as. That's why I started going towards care burden. Care burden has a definition, which you will probably recognize to some extent, some people more than others. But it's a high level of stress that is the result of dealing with a new situation, caring for somebody who has a diagnosis of dementia, could be any disease as well. And this creates a strain on the person who is, supporting, trying to help the person with the dementia. So, as I told you, having the different dementias, seeing that people exhibit different symptoms because of the different types of dementia, you see that the families are going to be affected potentially a bit different, because the person with dementia exhibits symptoms which vary depending on the subtype. So what's the impact of the different dementias into the family members? And why do we need to know that? And I'll get to that in a minute. So first of all, we did a study trying to understand how frontotemporal dementia and the different subtypes, the different presentations that you're probably familiar with, affect the spouse. So in this study, we had people who had the behavioral presentation, the family members responding, and these are all spouses. Also people with semantic dementia, the spouses with semantic dementia patients, the spouses of non-fluent aphasia patients, spouses of Alzheimer's disease as well, and also cortico-basal degeneration and progressive supranuclear palsy. So we wanted to combine them to try to understand what is the impact and compare between subtypes if different dementias are affecting family members differently. We suspected it would. So we had 85 participants. The average age were about 59. These are the carers' age. And the majority of them who responded were wives. So what this graph is showing to you, so on the horizontal line you see the different dementia subtypes, and on each bar represents the proportion of people who have burden, high levels of burden. So if it's gray, it's high proportion, it's above the normal cutoff, what you would expect. So people are extremely burdened. And it might not be a surprise if you're familiar with behavioral variant FTD. These are the carers who are mostly burdened. And these, when you compare people in very similar lengths of disease, so different dementia subtypes. Sorry, the question was which one is PCA? And unfortunately for this study, I didn't have PCA carers. So this one is just frontotemporal dementia and Alzheimer's disease. I'm sorry, I don't have PCA information on this one. So these are the different subtypes, and it's people who deal with behavioral variant frontotemporal dementia. These are the most burdened carers. The other dementia subtypes also, a proportion of carers report high levels of burden, but when you do statistical analysis, it's not as high as in behavioral variant FTD. So what's the message here is to remember that different dementia subtypes are affecting carers differently. Also, this is a more complex graph, but what this is showing here to you is that here you have the scores of burden. So again, the same people who answered before, but this is frontotemporal dementia only, the combination of the aphasias and the behavioral variant. and this severity of the disease. So what you're seeing on the diagonal line is that as the disease progresses, the burden of the carer, the family carer, the spouse increases. This is probably obvious to the family members, but this is not obvious to clinicians and to researchers. So by doing the more systematic investigation, we have evidence that the support that we have to provide for family members, especially spouses in this case, has to increase as the dementia progresses. Is it clear, the graph so far? Okay. This is a study we're currently doing, it's not published yet. This is a bit more complicated, but the message here, as you can look at the lines, we're looking at 3 different subtypes. So we have now behavioral variant frontotemporal dementia, we have the semantic dementia, and the ALS frontotemporal dementia. Are you familiar with ALS FTD? No, okay. So it is well accepted and known now that a proportion of people who have frontotemporal dementia, especially the behavioral variant form, might develop motor neuron disease. So the research between motor neuron disease and frontotemporal dementia has come much closer these days. The same is true for people who have motor neuron disease. So the motor neuron disease patients, a proportion of them will develop frontotemporal dementia. This is confirmed pathologically, genetically. There's loads of biomedical understanding to that. But the practical research is new now as well. So we're trying to understand how this continuum between the 2 diseases actually affect the families so that we can plan the services better. So we had carers for over 5 years, some of them, some a bit less. We're trying to understand how the burden that they report is changing. And in this case, we had the same families answering the same questionnaires for over a long period of time. So this is a longitudinal study, over 3-5 years, depending on the family carer. So what we see here is that, like I pointed out before, behavioral variant FTD carers started at very high levels of burden from the beginning of the diagnosis, and they continue to be high. There's a little decline there, but that's not statistically important. Importantly here, the semantic dementia carers, they start at a lower level of burden, but that is increasing significantly as time goes. And for frontotemporal dementia with ALS, this is similar. So it starts lower, but it increases. And we're trying to understand why is that happening with these other 2 diseases. What exactly, which are the factors? So in this study, we had a number of factors from the patient symptom side, but also from the carer side. What seems to be the case is that because we might not be able to date have informed well, or the services are not understanding well the changes that the disease brings, the carers are not as prepared for what is coming next. So information is critical at the diagnosis time, but also for the changes that might be coming later. Because what we also found in this study is that the semantic dementia patients, they exhibit a massive increase of behavior change, that it wasn't there as much at the beginning of the disease, but it appears later. So the carers need to be better informed potentially about that so that they can understand the changes they are facing. In the same case for ALS, for motor neuron disease, if the families are not aware that these changes might occur, it's harder for them to understand how to manage those.
How do you measure burden?
Oh, that is a very good point. Okay, so the question was, how do we measure burden? And as anything in psychology, we're trying to grasp a feeling, emotions, into ways of scoring with a number. So there's a questionnaire. The most common one used in dementia is called the Zarit Burden Inventory. It contains 48 questions, and it taps into different aspects of how the person feels about the situation. And by scoring that, and people use, when they developed, they compared people with burden, people without burden in different settings. And in dementia research has been used widely, so it really detects well. So you do generate a score, a figure, which will give us a cutoff of very marked burden or low burden. So psychology research is transforming feelings and emotions into numbers. I know it's not perfect, but it's just a way of us starting. Okay. But how about the carers who are not spouses? So again, by interviewing families, you're interviewing them because of the symptoms of the patient, you're interviewing them about their feelings, and you realize, well, there's children in the house, there are people still in their 40s, 20s, depending on the family, and dealing directly every day with the issues of the parent who is affected. So we try to understand that, and looking at the literature, at the research, at the papers and books, we couldn't find anything in frontotemporal dementia. So we did a pilot study on that. So we're writing this up at the moment, but what we did was we used technology, we used a website-based survey to be able to attract as many children as possible. And we had 49% of the children had parents with a behavioral form, 24% had people with CBD and PSP, with the atypical Parkinsonian symptoms as well, people who had parents with no-fluent aphasia, and people who had a parent with semantic dementia. The majority of them were, again, daughters. This is something which happens generally when it comes to research. Women tend to participate more often than men. We don't know exactly why, but it's a known fact. That's why there's always lots of daughters and wives. 21% of these children were the main carer of the parent, and 20% were living in the same house. So the majority were not living in the same house anymore, but they wanted to take part because they were feeling affected by that. A good proportion of them had left because of the parent affected. So that was the best arrangement the family found, because the person was extremely affected by the parent. So that's why they were not living anymore in the same house. So what we found might not be a surprise again to you, but children living in the same house versus children not living in the same house. So the higher levels of burden were reported by those who were still living in the same environment. And this is statistically important. So there was a marked evidence that people living in the same house were more affected. What perhaps more surprising was that the level of burden was the same between the spouses and the children. So when you look at the statistics of it, the children were equally affected by the disease, by the burden they were reporting, as the parents were. However, as a clinician, when you interview them, you do realize that things are different. And we're trying to then understand what is the difference. Because if we understand the difference of the factors of what is exactly pushing the burden, we can plan better what we should be doing to support. So the next step of the research was trying to understand that. So as you know, a person with dementia, the spouse, and children and friends, it's quite complex because people have different coping styles. So they respond to the situation in different ways. They have also different beliefs, different personalities as well. So no doubt, carer burden is complex. That's also the family history, the issues prior to the onset of the dementia. So, trying to answer what is behind burden. So for this next stage, I'm just going to compare spouses versus children, because that's the data we had available. We didn't include paid carers or friends. We only had family members. And what we tried to do is actually combine, again, issues to do with the person with dementia themselves, like what the dementia is causing, is bringing as symptoms. For example, the stage that the disease is, mild, moderate, severe, changes in the relationship that might have occurred because of the symptoms. So some people become less caring, some people become perhaps more controlling. So we have ways of measuring, again with questionnaires, and we have strong methodology to justify the questions that were chosen. So these are validated questionnaires. But we also put in the mix the age of the carer, because there's evidence that the younger carers will have higher burden. We wanted to see the social network, because previous research of ours had shown that the research the social network that the carer has is very important to reduce the burden. We also put the depressive symptoms of the carer and anxiety. As you can imagine, I'm sure you have other points that you would think are more important than these. But when it comes to statistics, we cannot put everything because we have to power the research. So, given the number of people we had, we tried to put the most critical information that we could find in the literature and the experience and measure that. So we put everything together and see what happens with the data. Oops, sorry, that went too quickly. Never mind. Burden on the spouse. So first we put all those factors, and we wanted to see which ones, statistically speaking, are going to explain the high burden that they are reporting. So for spouse, in frontotemporal dementia, the stage of dementia is the main factor. And it's not a surprise if you remember that on the graph where the diagonal line was going up as the disease progressed. But also important for the equation was the change in the relationship when the person with dementia, when they have changes in the emotional process, they become less caring. So that was driving also the burden the carers were reporting. But also equally important, not as a bit less, was the depressive symptoms that the carers were reporting. And these are also measured through questionnaires. So stage of dementia, the key point for spouses. But how about the children? We put the same factors and we wanted to see what was happening to the children. And when you do the stats, the only factor that remains is the depressive symptoms. So what are we saying here? We're saying here that for the spouse of the person with dementia, the stage of disease plays the major role in the burden they're suffering, the reporting. So the support has to go through an increase as the disease progresses. On the other hand, when you think of potential services and support for the children, it doesn't matter which stage. It's the depressive symptoms they're reporting. So the children need to be supported throughout. And it doesn't increase. It's very high at the beginning and it remains high. So we saw that depressive symptoms appear twice, both for spouses and for the children. But not everybody is depressed. They're reporting depressive symptoms in a questionnaire, but that doesn't mean they're depressed as clinical depression, that people need medication or intervention. So we're thinking about that and reading more, and it looks like the depressive symptoms might be more related to actually the grief, the anticipatory grief that people are going through. And this is common to overlap with depressive symptoms. So this is not depression. The carer is not clinically depressed necessarily, but they're reporting emotions that are very overlapping with potential the grief, the loss that you're suffering, as they goes. It's not like in cancer when there's a different type of grief because it's a terminal disease and usually quite well understood, and there's years that people have better mapped the symptoms and how to get support or retain support. In frontotemporal dementia, it's a different stage. People are much younger, people are still working, and the type of loss is much more extended. It goes through a very large number of years, and you see the person losing abilities as the years pass. So the next research we're doing now is investigating grief a bit more carefully, because first when you talk to a doctor, and I was discussing this with doctors, he said, maybe is the question, he was being really instigated, is it the case of reducing the depression symptoms of all the carers and that will improve the report of burden? But from the psychological point of view, that might not be the right way to go, because grief is natural, it's normal, we can't stop grief. And you have to go through it. Everybody has to go through grief to be able to come out the other way better resolved. So that's why it's important for us to investigate this further, because otherwise people might think, I just have to take some antidepressants. No, that's not the answer. So we have to investigate this further. Okay, this is just a summary of what I just said about the factors. But then you're asking me, what can I do now? What you said is not a surprise to any of you. So I suppose what I said hopefully reverberates to what you feel, but this is really systematically evidence that didn't exist before. It's a bit scary to think that obvious things that people go through were not very commonly researched to date, but things are changing. So from this experience you think, oh, myself as a clinician and a researcher think, well, we have to do something which is appropriate and targeted. And how do we do that? So we found a very nice program developed in Canada for people who had dementia in general. In that study, they didn't separate people by subtype, they just put everybody together. But it was a lovely program done in the whole of Quebec, and they showed it's a program. It was 15 weeks, intense 2 hours every week. People had to commit to that, and they learned a series of skills, and all to do with the reduction of stress. We did run that in Australia. I should have told you I was in Australia until last year. So after 6 years in Australia, I'm back in Cambridge. So we ran the program in Australia 3 years in sequence. So we have now a nice number we are writing about. We did write something already on that result. But I cannot give you 15 weeks in half an hour. But I'm going to give you a flavor of that because we have very good evidence of what happened to that group. And ideally we want to work on towards creating opportunities for these groups to be run. And I can imagine some of you thinking, are you mad? 15 weeks, I'll come for 2 hours. It's a long ask. But the feedback from those who did that step in Australia, and some of them were driving an hour and a half to get there, because Australia is very large, people don't have centers. They said, please tell the carers that was the best time we've spent doing it, because people should know it's worth organizing, other care or some support for the person to be at home while ago. So that was very, very lovely feedback from the family carers who took part. So what can I tell you about the program in a few minutes? One, we don't have the magic pill. So the idea of the program is that you're going to deal with symptoms and problems leading to, the symptoms of the dementia leading to problems. And the issue is to select a problem. So for the program, we worked with one program throughout the 15 weeks. So you can imagine how intense that was. And there's no time. It's a bit like education, really. There's a manual. We have to go through and cover every aspect. But you learn how to break down one selected problem in parts. It's really slicing it. It's not different from project management. If you work in project management, you'll be familiar with some of the terms here. And you're trying to break down the problem in parts which could be changed and other parts which are not changeable. And by trying to bring up a massive problem and breaking it down into small pieces, you start realizing which parts I can do something about it and I can address, whereas other parts I cannot do much about it because it's a disease. And at the moment there's no pill to stop that syndrome. And how can I manage that? So the changeable parts of a problem, you can develop new strategies. You don't have to do that alone. You can do it with friends or family members. You try to learn how to do things in a different way, and perhaps changing things around the house on the routine. So you try to problem solve that aspect. How about when things are unchangeable? Well, you have to understand better, and that's what you're trying to do here today, getting more information, reading about it, you go to the web, you talk to other people, you talk to doctors and therapists, and it's really understanding. It's an emotional process which takes much longer, of course, and some people will be much better at dealing with the emotional side than others, whereas others will be much better dealing with the problem-solving aspect, which is more concrete. Everybody's different, but what we do in the program is trying to teach people to use the different strategies, because there's no point in trying to apply problem solving for something which is unchangeable. You're just wasting your energy, getting more frustrated. The key thing as well in the program is that there is an alternative supporting strategy, which is seeking support, which works for both changeable and unchangeable. And again, it's what you're doing here today, you're seeking support. So, family, friends, and services. I run the program with a very expert dementia nurse in Australia. She's a consultant. And we both wrongly thought that seeking support would be the easier strategy to work with the carers. And we were very surprised to see that was the one everybody found it most difficult to use, because most family carers didn't feel they had the right of asking for help. And the majority, some of them were quite quick at, asking for help, but that was really the minority. The great majority felt they could not seek support. They were not allowed or entitled. So we spent quite a long time working each of these strategies. 15 weeks, you can imagine, 3 weeks, 3 weeks, 3 weeks, and then breaking down problem on all the 3 weeks. So it takes quite a long time. And we go through the group, so everybody who's committed to the group has to stay. Okay, like I told you, I cannot give you 15 weeks in this time, but how can I apply this in practice? Just to illustrate to you how this works. And again, now I'm going to use my occupational therapy side, because I think if I give you a concrete example and you can start transferring some of these strategies into real life. So first of all, I'm just going to show you an example of an activity performance, and then we're going to apply that. So thinking of preparing soup, oh, that's one animation, it's not so good, sorry. So if you think of preparing a soup, you're thinking of people initiating the task. They have to have the idea of making a soup and go to the place. They will have parts of this, the activity which is to do with the planning and solving problems. And this is the execution. So initiation, you have to get up or go from where you are and reach the kitchen to be able to get to the soup that you want to prepare. You have to find all the ingredients you need. You need to know where they are until you finally execute. So what we do with an activity performance, we are going to break down between initiation, the ability to plan and solve problems as they go, and how to execute until the soup is there. So when you see a problem, let's say the person is having difficulties with making the soup. Maybe the person used to make soup on Fridays for, it was part of a routine, and now they just don't do it. So it's try to understand why the problem starts. Is it because they're very apathetic, they can't get initiation to go? Or is it because they're confused with the ingredients? Maybe they're having naming difficulties, maybe they don't know where things are, maybe they can't see so well and process the images, what they're saying? Or is it to do itself with the process of executing? They're unsafe. Are they forgetting things in the stove, or are they cooking for 10 instead of cooking for 2? So it's getting a problem in this example, not being able to make a soup, and break it down to see which part is there that is happening. And some of the problems there are parts that you can help address. You can help by facilitating things in the kitchen, or help by having an alarm on somebody who triggers the initiation of the task. But there'll be other parts which you might not be able to do. Maybe they used to cook for 10 because you have a large family, but all the children are gone now, and there's no point in arguing the person to not cook for 10. It might be easy to let them do and then freeze some of the portions, or be creative about the parts that you might not be able to change because the person has a rigid routine, and that the recommendations you should just circumvent to go around it instead of confront it. So I'll give a few examples now how to apply the changeable and unchangeable again by stage. So I'm just going to go through two very simple examples of stages of the dementia, because I'll speak about this more thoroughly next week. So for the mild stage, you have to remember again about the changeable aspects and problem solving, understanding the symptoms, about accepting something which is unchangeable, and through to support. So if you think of at the very mild stages of frontal dementia, for example, writing, looking at correspondence and booking trips, it's an early common problem that we've identified through many families. So what is the way of addressing that? Well, that's a very good example of changeable and seeking support. For writing and looking after the finances, for example, these are very clear, concrete problems that can be worked through changeable aspects. So breaking down which part of the correspondence, is it because it's a spelling problem? Or is it because they're supporting the spelling or revising the draft? Or is it to do with the fact that people are hiding the correspondence? So then the answer might be, let's divert the post to the son or the daughter, or let's get a post box. Booking trips, the person used to do all the booking trips and now they can't do anymore. So things that can be addressed, so maybe the support is having somebody do it with them, or going through the process of checking what was the booking plan, did they do it, or going through a travel agent together instead of doing everything online. When it comes to finances, again, breaking down which aspect of the finances the person used to look after, and what is the part exactly that they need help. What we're trying to say here is that whenever possible, not to take over, because the person still has remaining abilities, that we can work with them to support them so that they can continue doing things safely and without risking. Of course, when there's a risk of money loss or things which are more complex, of course we have to intervene earlier, but if it's more about supporting the person, then there's strategies you can apply. A very common early symptom that most frontal dementia patients will exhibit is change in the affection. And they might not demonstrate affection as before. Now, that's something which is unchangeable. This is to do with the changes in the brain, which affect the emotional processing. And this is something you cannot address. That's not a problem-solving type strategy. And that's when seeking support or understanding more about the disease, understand this is not a personal reaction to you, it's important to work through the acceptance. Of course, this is all very simple as I speak here. I'm just trying to show you how things can be addressed differently. And of course, each of these processes will take months, sometimes will take years, especially in coming to accepting some of the losses and the symptoms. But I think the important message here is try to understand what you can do, what you cannot do, will vary with what you're facing, and you can try to divert and direct your energy the best way you can. In regards to the moderate stage, again, there will be some of the changes will be changeable, things you can help support, but there will be all the symptoms which are really unchangeable again. So here, very common, people become quite restless. They might develop sweet tooth. Uncooperative, doesn't want to do what the family is proposing to do, or doesn't want to accept help sometimes. There's various forms of lack of cooperation. Or maybe they're doing house chores and the result is not looking as good as it used to be. Maybe the cleaning, not so good, or the dishes are not properly washed as they used to do. Driving, of course, it's an age. I'll come back to that in a sec. But thinking of these, it's clear again which ones can you direct one way or another. Restlessness, it's changes in the brain again that we cannot make a person stop. It's usually without a specific meaning. They might just be pacing around. So it's not about trying to change that. It's trying to understand and keep the person safe. The sweet tooth, it is a common one that people will ask, well, but he or she is eating so much, how do I make them stop? Well, the first question we normally go through is, do they have diabetes? Do they have any other health issue that would be really a problem if they eat the sweets really? So if there is no other health issue, usually what we work with the family is, why not? Why would that be really a problem if the health is alright in terms of diabetes? And if they derive so much pleasure of, going getting the sweets from the shop and coming back and eating them. It's a difficult one to accept because the person perhaps used to be very slim and they've changed because they're eating so much, but it's not something which is potentially harmful. So there's no main reason to change. I think what we work with dementia symptoms and the changes with the families, which aspects are important for me to try to support and change back, or which parts can I let it happen because there is no such a major issue here. And trying to adapt your own behavior towards what is happening, that's one of the critical challenges. With the house chores, what we usually would say is, and some families do that quite well, they'll let the person do. and then maybe later, discreetly, they will just fix it what might not be looking as well as it used to be. And in that way, the person continues to be active. They are doing what they used to do that's important to them. If the quality has dropped a bit, well, maybe that doesn't matter, but they're doing it. Driving is usually a big issue and a big concern, and in the aphasias, what we've seen, and the research is starting to show, is that most people will pass the driving test. And as long as, the DFLA has been informed that the person has a diagnosis and an assessment is booked, they might not be able to communicate so well, but they can drive for quite some time, especially if you have semantic dementia. There's no problem. There's no visual-spatial problem. There's no problem with remembering routes. People don't get lost. So as long as the person passes the test, is everything easy when you don't feel unsafe with them in the car. There's no reason for why they cannot be assessed and continue to drive. And being uncooperative, we had a very good example from a family in Australia where the father had a liver variant, FTD, and it was very hard to entice him to do social activities with them like they used to go, for example, for a picnic. They used to love taking the boat. They had a boat, so they would go together, do a little, day trip, take all the picnic and come back. So the wife and the daughter were thinking, how can we make him come? Because he just wouldn't. And he was very fixated on his sweets. So the daughter, she told me quite proudly, she said, well, you know what I did? I just thought, Dad, if you don't come, it's your problem, but I'm taking all the sweets of the house. So she packed all the sweets in the cooler and took it. And then he joined because he wanted to come with the sweets as well. And I said them. And they had a quite lovely time. And I was just giving her feedback, saying, well, this is great. You managed to find a behavior which is very important to him and normally classified as a problem. And she inverted that and used that as a way of getting him out to join them socially. So, of course, it does take time. It does depend on how you are or how your relationship was before. And all these factors are important, but when one reaches a point when you can use some of the symptoms in your favor, and that might be a good way of getting things better accepted and getting the person involved in things which are important to everybody. Okay. So just as a general summary, let me see if I'm on time. What we're trying to summarize after all these graphs and some of these errors is that caraboid is of course very complex. And here we're trying to understand what's the iceberg. We look at the tip, we're trying to understand what's underneath really. Well, how can we break this iceberg down so that we can address and help people be supported in different factors. It's important that we remember the issues to do with the dementia subtype, like I showed in the earlier graphs. Certain dementia subtypes affect family members more than others. But there's also issues with the factors which are more pertaining to the family member, and those we can change, we can help support. I think what is challenging dementia is that the symptoms in the person we cannot treat yet. There's no pill, there's no pharmacology, I don't need to tell you that. You know that well, but we know that other factors which might be outside the person are more malleable, and we have the power and the opportunity to learn about those to change some of the issues and make things a bit easier. Spouse and children, this is again important to think about this around the person with dementia, and those factors of burden are different. And we're trying to investigate a bit more about how we can understand the role of anticipatory grief and how can we support that. We're also trying to understand what's the point is understand the factors so that we can tailor, we can plan services that can support the issues that are really relevant. Well, one problem that I have, and I'm a clinician myself, is that so much of what clinical teams do is what they think is best for the family. But what is missing is us understanding in a scientific way what is the family telling you, what are they showing, so that we can change the services the other way around. I think that's one key thing I'm very excited to pursue, because I think that makes sense. Just thinking of the example of the soup, I was just just trying to help you understand how you can break down one type of common problem, maybe in the kitchen or in the finances or in the house, very practical of course, but trying to see which aspects you can address or not. And again, thinking about all the common changes you see inevitably in the mild and moderate stages. So just to remind ourselves again, aspects of the problem which are changeable, we can address with problem solving. We can apply that. But when it's unchangeable, which are symptoms which are more related to the behavior, restlessness, change in emotional processing, these we are not able to change yet. But I think acknowledging it, understanding that the person is not having an attack or responding negatively to you because he or she always done that. So of course now they do it again, or they're doing worse now, they came to annoy me. It's really trying to distantiate a bit and remember, of course it upsets me, but it's not intentional. So that's when walking out of a room or counting to 100 and breathing deeply might help. And seeking support, just to remember, that's one key thing that works for every problem. And of course, you are a very selected group, you're here already, so you're doing it. And it's important to remember how valuable that is. And don't be afraid of going for it. Like I told you, we were surprised to see how the carers found so difficult to access support and allow themselves to ask for help. And there's so many people usually around trying to help, but they just don't know what to do. And usually when you interview and break down the interview with the carer, the family member, they say, oh, actually, my neighbor offered, and also the guy who plays golf with him. But have you told them what you can do? Can he pick him up? Oh, no, I didn't. Well, they're waiting for you to say, because they cannot come and tell into your house and say, I'm going to do that. Unless you're such a close friend that you have the freedom to come and say that. Most of the time, they're waiting for you to say, very specifically, very concretely, can you pick him up and bring him back while I'm going to do something? So, yes, just to reiterate how important what you're doing here and how we have evidence that that works. So, thanks again for everybody. These are mostly Cambridge and Australian carers and patients. Most of the research, or actually all the research I showed you today was done in Australia. I was 6 years there. And I'm back in Cambridge, so I'm hoping to get some British funding because at the moment I'm applying for this. So these are all non-British funders. Hopefully continue to develop a research program in Cambridge which is addressing the more practical side of dementia. And I wanted to say one last thing. Oh yeah, very interested to discuss, is that I've been to many different countries. I'm from Brazil, but I have a Japanese ancestry. I work with Indian carers, because we have studies there. We have studies in Australia, studies here. And it's really important and exciting to see that regardless of culture, there's so many factors that are just the same for everybody. And that's very powerful because we remember that we can address them equally in different contexts. So, yeah, you're not alone. Thank you.
Point about lack of affection. You mentioned it under the mild stage, and I would say in PCA case, in our case, my wife's Brazilian as well, by the way. It continued through the mid stage.
Oh, okay, sorry.
But she's now further advanced, and she's more affectionate now than she was in the mild or medium stage. So perhaps it's not all downhill all the way.
No. So the 2 points to your question or point. What I meant by mild, it's just that what usually appears in the mild stage, but that I should have reiterated was done in frontotemporal dementia carers, patients, not in PCA specifically. What is also a very important point you just raised, that the symptoms change. And what might have been a problem initially then might not have been a problem later. And this is something which is very challenging for us researchers and clinicians because it changes to you too. I mean, there's also what you might have reported to yourself as upsetting might not upset you later. For example, some families will say, oh, he's pacing so much, and then maybe after 3 years he's still pacing, but the family is used to that. So we need to break down the factors a bit better, and that's where research is so important for us to try to generalize what is happening to certain groups of people, so that we can come with the best tools to offer you. But I agree, it's this challenge of the dementia itself, that symptoms change so much.
Yeah, I suppose there's a negative aspect to what I was saying as well, in that your presentation showed that the studies you've done are quite complex, and the results are quite complex. What I'm saying is it's even more complex than that. There's a third dimension and maybe a fourth.
Oh, I completely acknowledge that. And I think the stats are not keeping up with it. We don't have methodologies that can encompass the complexity. So we start with a little aspect of it, and I'm the first to acknowledge so much of it we did limited because we cannot put everything in. But it's...
But very, very interesting and very worthwhile. Thank you.
Thank you.
In your clinical work, you've talked about working with carers. Do you have any experience in working with carers and people with the diagnosis as couples?
Together? No, not yet, no. We have a program, this program that I mentioned, the 15 weeks, we're hoping to start now in this year in Cambridge again, because the ethics, the approval of the authorities is coming through. We have another program which is not for care abandoned, then it's working with the couples. So is that what you meant, any form of?
Well, I was thinking about, dealing with carer burden and the burden of the person with the condition, but, working it through as a couple, whether that was something you thought might have potential.
We do have that, there are the research showing that this is very valuable, but the first purpose is not about reducing the carer burden. It's more about reducing some of the symptoms in a non-pharmacological way, and increasing the skills of the carer. So the burden might reduce as a collateral benefit, but it's not the main target. But we do have programs, and we're hoping to also start Easter time, waiting for the approval from the authorities. Yes, definitely room for that.
Hi there. You mentioned when you were talking about the soup example that when the person in that example you used was wanting to cook for 10, but actually only needs to cook for 2, and you said the research is showing that you should find a coping strategy rather than trying to confront that. I'm just wondering, is that always the case, or are there times when it's beneficial to draw a boundary and kind of say no? Or...
Okay, but can you just tell me which is the type of dementia you're normally dealing with, because the answer might differ a bit.
Non-fluent aphasia.
Okay. For I think 95% of the time we try to work with the carers in not confronting, because the outcomes of that are not going to be good in any level. I mean, for the person, for you, and for the memory of that event and how that builds up. So 95% of the time, no confrontation is the key, unless it's unsafe, unless there's a risk, driving or dealing with knives or fire or things which might be posing a risk, being lured by people at the door and spending so much money because people are selling stuff at the door. So unless there's a risk, we would normally not recommend confronting it, but adapting it and finding creative ways of addressing it. Is there maybe somebody down the road who needs a bit of soup and, becomes, I'll bring a pot for you as well every Friday. Just trying to find other meanings, yeah.
Carer burden. One of the first things that sprung to mind when this was discussed was counselling and therapy, which you haven't really touched on. And for carers to go perhaps through their GP or through somebody with a clinician to go and get help with counselling, I think, is very important.
Absolutely. In clinical practice, when a proportion of people are definitely on the subgroup who definitely would benefit best by going to one specific counselling sessions, and we do recommend that. The problem is not everybody can access, and everybody wants to go that route. There's still some stigma when people think, I don't need counselling, it's not for me, or I don't like that. Similarly, there are not people who don't like the groups. So I think it depends on the person. There will be the best route going through one-to-one or going to group, but definitely they should coexist. One of the issues some of the family members bring back to us is that, well, he or she doesn't understand dementia. So they're doing general counseling. So trying to tap into the services who actually offer counseling, who understands dementia more extensively is usually the best way. I've seen other families who came back quite scarred and they don't want to do it again because they thought, oh, he didn't or she didn't. And that's really a pity because in so many cases the person will benefit immensely from that. So my view is they should coexist. Sometimes it's hard to find a service that can deal with that.
I think also, Nick, you mentioned accessing counselling through a GP. Ideally, the counselling would be a sort of expert counselling service that would run alongside the diagnosis, and Susie may have more to add on that. But I think just to mention that there are counselling facilities and services available through organisations like Carers UK and Cruise Bereavement. So if the GP doesn't come up trumps necessarily, don't necessarily draw the line, try other avenues.
Hi. I think I have a difficulty understanding the difference between the symptoms of the condition and the uncooperative aspect, to follow on from this gentleman just here. I'll give you one example. My husband was completely addicted to apple juice, and one of the problems is incontinence. And we had a session with an expert who said, "Oh, cranberry juice is much better for you," and immediately he switched. Whereas, other aids are just impossible to move him on from. So I don't know how you distinguish.
The truth is, it's a very good example. So many things like that. I don't know the answer. We don't know the answer. Why certain behaviors seem so rigid that suddenly it's possible to switch, whereas others that you think, oh, yeah. So the truth is, the changes in the brain are so complex that we also try to translate that into one thing or another, and we don't know the answer why sometimes one thing works and the other aspect didn't. So that is the point of why not try if it's just a juice, for example, maybe try on the flavor. But once it didn't work, it's not insisting on that. Maybe try another approach then. What I'm trying to say, we don't understand well the brain enough to understand why sometimes they're so cooperative and sometimes they don't. I'll give another complex example of a gentleman who used to go for coffee at 3 o'clock every time. He was quite severe. He started with a behavioral form. The wife had a trip. So the carers were coming and the children were supporting him while she was out. So he always had the amount of money ready for him to go to the cafe. But she delayed the return, and there was a gap of us, like 6 hours between the children not being in the house to give him the money and her. And he was practically mute. He wouldn't say much. But he would go. He wouldn't get lost, of course. He had BV. He would go to the cafe. What did he do? He went to the bank with his card, and he got the money out. He signed. We don't know. The wife said, I don't know how he talked to the cashier. He signed, he got the cash out and went for his coffee because he wanted to get to the coffee like he always does. And she said, he hasn't been to the bank for 5 years. How could he do that? And the answer is we don't know because it doesn't make sense to teach. But somehow there's certain motivations or behaviors that abilities which are there, but sometimes apathy or other issues are much more important. So he doesn't care about finance in general, but for some reason it was for his target, so he went and did it. But the true answer is we don't know how can the brain do that if for the things it doesn't.
Hi. I was interested in a lot of what you were saying. I tend to use a lot of diversionary tactics at home. But I was also interested, I care for a relatively young PCA husband, and we currently have a 23-year-old daughter, our youngest one, living at home. So I was quite interested in what you were saying about the effect on the children. I've left her this morning, come down, I had to get an early train, so she's had to look after Dad and give him his breakfast. He can get through the shower at the moment, but he does have some difficulties with his clothing. He can do it on his own, it can take a lot of time. So I'm just
concerned at the effect she's having to deal with as a young person with her dad. And also, she gets quite impatient with him with certain other aspects. He's got a very distinct idea about security in the house and it has to be secure. And it doesn't matter, Dad, we're home, the door is locked, it's fine. That's not enough. Now, how can I help her to understand how he sees it or how best to deal with it? I will use diversionary tactics, but she's, well, no, he knows how to do this, he knows it's not important. It's very difficult for a young person to take this on, and I'm also, as a mum, very concerned about how she's dealing with this.
Yes, of course. I think, Jill, I need your help on that one, but I'll answer first my bit, which I thought. I think what it looks like she's having great difficulty in adjusting to the diagnosis yet. So,
no, sorry, I think she actually knew about it before he did. She pointed it out to me.
Oh.
Before diagnosis, she's very astute and clear that way, but dealing with the aspects of it, I think.
But I think it's a combination, isn't it? I mean, she can rationally, she could see something was happening, but that doesn't mean emotionally it's easy for her to accept. So I think the fact that she's trying to confront the symptoms, but he knows how to do it. Why do you do that? Shows to me that she's still struggling to understand these are not intentional or there's some other issue going on. It doesn't mean she's not intelligent, of course she is. It's about the emotional aspect, which is, I think, probably harder to deal with. And I think understanding more the condition of, has she read more or has she had the opportunity to meet others?
Perhaps she has an older sister she's very close to, who lives away from home. They do talk together, which I'm really grateful for. They support one another, but their experiences of this are completely different. She's living with it, her older sister isn't. And I'm quite conscious that I don't want her to have to deal with this all the time. I'm trying to encourage her to lead as normal a life as possible.
But I think you did the right thing in that you're empowering her. I think this is another way also of approaching why she gets to the point where she might be using structures like yourself. But I think it looks like the process is different. I think you're a spouse, she's a child. The loss you're going through, like I was trying to say, it's different. But I think by empowering her, by leaving her with him and trying, she has to do this today, she'll come out of this experience. Of course, she might be a bit upset, but also more empowered because she knows how to handle him and help support him. So I think what you're doing is in the right direction already. It's just that the timing might be a bit different for you both, and things that you can deal more. Yeah, you can take the distance, help him, support that, analyze it. She might still be adjusting to that and bringing all the full picture together.
So just go with it, because at the minute she's not keen to get involved with the awareness group or Facebook and so on.
I think you're raising, Alison, 2 or 3 different issues. And really important. No, not to say sorry at all. It's really important. I think, for one, there's the issue of as a child rather than a spouse. But within that comes, even within our children have different characters and different personalities. So one child may respond one way and another child another. And our children are very different to us as mum or dad. And so there will be a natural conflict, or conflict's too strong a word, but a natural sort of difference in the way they respond to dad or mum and their diagnosis, as there would be in any other life trauma that you were unfortunate enough to have to deal with as a family. So for one, there's sort of putting it into the normal. For 2, I think it's really important that you raise it so emotionally, because I think it's important to recognise the effect on parents of having to accommodate a child's understanding of an illness in their father or mother. So it affects the way you want to mother your children in a very subtle way, outside of your daughter understanding the diagnosis that her father has. And so there's a huge burden that you're dealing with. I use you personally, but I mean generically anybody who's in this situation, over and above the logical that we're looking at. It's affecting your mother relationship, your mother-daughter, mother-son, father-daughter, father-son, in a very subtle but sort of implicit way. And thirdly, I think people do say, time and time again, that there is a need for family member-specific information. So, for example, we had one lady whose brother-in-law stopped coming to visit them at Christmas because his brother was behaving so badly to her. She understood why, the family understood why, but his own brother saw it as outrightly sort of unacceptable behaviour for his own brother to behave in that way. So family member-specific information is probably also a need that we ought to be addressing, and certainly when it comes to children. And I thank you because you've reminded me that on the table at the left we have some Alzheimer's Research UK questionnaires, and I appreciate the questionnaires are directed at slightly younger children than your daughters, but they do have two versions, and I've left a supply on that table along with a free post envelope because they are working to try and develop younger child and older child specific information. Some of the diagnoses, the frontotemporal dementias, do have quite a lot of age-specific information. PCA doesn't, and I see it as a gap, and one that we could easily work together with the expertise in this room to fill.
Thank you, Jill. That sounds good in that way, but the other slight issue we have is that she sees this as taking over our lives. And that's why she wants it. And I think that's part of her struggle. Yeah. Well, it's not robbed her, but it's difficult for it not to take over.
I just would make a quick comment to that. She's not wrong in that it is taking over. So I think it's really validating that too, because sometimes she would just need you to recognize that we've had together and go through a bit of the pain of that, and perhaps having a bit of time which is just the two of you regain back in an activity or something that you both could do that you used to do before, more individually, but she's not really wrong, so I think that's important to also validate that from her.
Any life-changing trauma changes the way you view the future, and a diagnosis like this is one of them. One last question before we...
I was just wondering if your research differentiated with the carer burden for children between genetic variants of the disease and non-genetic, because I think children where it's genetic, which a huge number of us are that, and I use research differently.
It's a fantastic point. Yeah, we haven't done that yet, no, because the facilities of testing the patients now, which happened much more recently, in the group I was working, so we didn't separate, and usually the groups were very small within these centers, so I think this is something more perhaps GenFi or other initiatives are able to do because of the numbers. But no, you're right, we haven't done that, and I think the perspective is very different once you know about the genetic risk.
I was saying there's a lot of literature in Huntington's disease, which is genetic, the field is just ahead of us, and so they have looked more at children and what it's like knowing that your mum or your dad has this thing that you might have. So it may be just one avenue to have a look at, to Google and see if it helps at all.
Thank you. We could talk all afternoon, but we do have to fit lunch in before Angela this afternoon, so thank you, Eneida.